Yeah, now it's live. You can check in your mobile.
Just a second.
Disconnect the call because it's live now.
Okay. Just a second.
Disconnect the call because it's live now.
All right. So, a very good evening, my dear students. So now, yes. So what I will be discussing in the today's topic, right? I'll just give you a brief idea of what will be the discussion of next 30 to 40 minutes. So in the next 30 to 40 minutes, I'll be discussing basically the questions related to neurology, because the session or the exam what we have in the nearby is the NIMHANS exam. So all the educators are trying to take up the sessions related to neurology, mainly to cater the students who are appearing for the NIMHANS, and the same questions may be useful even for your AIIMS exam and as well as even for your NEET PG entrance exam as well. So what I will be covering in this today's session, I will be covering clinical based questions, true or false type of questions, and some of the image based questions. So first, let me start the discussion with the clinical based questions, right? And at the end of the entire discussion, I will also give you a summary what we have discussed in this particular 30 to 40 minutes. But the discussion will be on these three type of questions which can be asked in your NIMHANS or which can be asked in your AIIMS exam and as well as NEET PG entrance exam, and all the questions are related to your neurology. All right, now, so right, so you take the first question. We have a 26-year-old woman and she is evaluated for decreased vision and eye pain, and her symptoms started 2 days ago with pain in her right eye with ocular movements. That means whenever she is moving the eyes, then she is having pain within her right eye. And over the past 24 hours, she has experienced a decrease in central vision in her right eye. And she has no significant medical history. Physical examination shows decreased central vision and pain on ocular movement of the right eye. There is afferent pupillary defect on the right, and fundus examination is normal, and rest of her examination is unremarkable. An MRI of the brain and spinal cord are consistent with the optic neuritis on the right, and there are two white matter lesions in the periventricular area. So this is the basic examination findings and investigations. I just summarize. Middle-aged female, 26 years. Main complaint is what? Pain in her right eye with the movement of the right eye. And there is also decrease in the central vision, which you can make out on examination also. Fundus examination is normal. Other examination of the central nervous system is unremarkable. MRI and MRI of the brain and spinal cord, they are consistent with the optic neuritis on the right side. And there are also two white matter lesions in the periventricular area. So this is the clinical summary of this particular patient. Now, what is the question? On the basis of this patient's presentation and MRI finding, which of the following statements is most accurate? The options are: patient has multiple sclerosis and should be started on steroids and glatiramer acetate. The patient has optic neuritis and she is at significant risk for developing multiple sclerosis in the future. The patient has optic neuritis, she is at no risk of progressing to multiple sclerosis in the future. Fourth option, the patient has multiple sclerosis and she should be started on mitoxantrone. So what do you think is the answer to this particular question? Okay, so I'm getting the answers, mixed answers. So Mad for AIIMS has answered it as A, and the remaining students, they have answered it as B. Now, so let me take the discussion now. So if you take this discussion, there are two things that we need to discuss in this particular question. So by this question, what I will be teaching you? I will be teaching you in this particular question how to diagnose multiple sclerosis, how to diagnose optic neuritis, and how to treat multiple sclerosis. That is what I'll be teaching you from this particular question. All right. Now, so let me take up the discussion on both the topics, that is optic neuritis and as well as the multiple sclerosis. So first of all, let me tell you, so two things I'll be telling you now. One, you should know optic neuritis, and second, you should know multiple sclerosis. Now, okay, so I have a mixed answers, A, B, C and all. Okay, fine. Now, first of all, you tell me what is the most common symptom? What is the most common symptom in multiple sclerosis? Any one of you? Most common symptom in multiple sclerosis. Yes, it is not visual manifestations. Mad for AIIMS, you are correct. So most common symptom in multiple sclerosis is your sensory loss. Right, it is your sensory loss. And followed by the sensory loss, then it is your optic neuritis or visual impairment. Right, visual impairment. Okay, and some of the textbooks also gives you the percentages. Sensory loss, it is nearly around 37%, and optic neuritis or visual impairment, it is around 36%. Okay, now what is this? What is the difference now? What is the difference between your optic neuritis and as well as multiple sclerosis? Let me discuss, and then we will go back to the question what I was telling you. You take this optic neuritis, right? So what exactly this mean? This tells you that the individual is having acute inflammation of optic nerve. Right? It tells you about the acute inflammation of the optic nerve. Now, what will be the cardinal manifestation? What will be the clinical manifestation of your optic neuritis? The clinical manifestation of the optic neuritis include unilateral vision loss and retrobulbar pain with movement of the eye. Right? Retrobulbar pain with movement of the eye. Okay, so that will be the important clinical manifestation what you will come across in patients with the optic neuritis. Now, how do you treat this and how do you diagnose this optic neuritis? See, the diagnosis, it is by your MRI. Right, the MRI of the optic nerve will show you the presence of your optic neuritis. Now, how do you treat this optic neuritis? So can anyone tell me how is the treatment for your optic neuritis? Right. So the treatment for your optic neuritis is you need to give intravenous methylprednisolone. Very good. So it is your intravenous methylprednisolone. And followed by that, you should give oral prednisolone. Right. Followed by that, you should give oral prednisolone. So this is what is the treatment for the optic neuritis. But one point what you should remember related to your optic neuritis is that, okay, see, when you give this intravenous methylprednisolone, right, see, these patients, they will recover immediately. But the point what you should know is, even without treatment, almost all patients, they recover within 4 weeks. Right, they recover within 4 weeks. Okay, so right, disseminated intravascular, yeah, we are discussing the optic neuritis now. Let me concentrate on this. The DIC part, let me take up the discussion later on when I am discussing the hematology, because we will be completely away from the topic, right? Okay, so the treatment for your optic neuritis is intravenous methylprednisolone followed by oral prednisolone. With that, the patient will recover immediately. Even though you don't give methylprednisolone, the patients will recover within 4 weeks. See, that is the story of your only optic neuritis. Whereas Now you take the story of multiple sclerosis, right? You take the story of multiple sclerosis. Now, can anyone tell me what is the name of the criteria? What is the name of the criteria for multiple sclerosis for diagnosis? What is the name of the criteria for multiple sclerosis for the diagnosis? Can anyone tell me? Very good, Banu. So the name of the criteria is McDonald's criteria. Right? The name of this criteria is called as the McDonald's criteria. Okay. Next. Now, if you take the okay. So yes, Santosh, I will take up the disseminated intravascular coagulation in the later sessions because this session is completely on the neurology. Let me concentrate on the neurology because explanation of the DIC, it will take nearly around 10 to 15 minutes. My session itself is around only 30 to 40 minutes. So let me concentrate on this particular topic. Okay. So in the further coming sessions, I'll discuss the hematology as well. Right. Now what is your McDonald's criteria? Right? So how do you, what is the consideration for the McDonald's criteria? So if you take this McDonald's criteria, how many symptoms should be there to consider it as McDonald's criteria to be positive? Minimum, there should be more than 2 symptoms. Right? Minimum, there should be more than 2 symptoms. And these particular symptoms, they should be spread over a period of more than 4 weeks. Right? So more than or equal to 2 symptoms which are spread over a period of more than 4 weeks. That is one. Next, every symptom, right? Every symptom should persist for more than 24 hours. Right? Every symptom should persist for more than 24 hours. Next, what is the other thing in the criteria? The other thing in the criteria is the presence of the MRI finding. Right? Other thing in the criteria is the presence of your MRI finding. And what is that should be there within the MRI? Remember, within the MRI, there should be minimum of more than 2 lesions. Right? And that should be of size more than 4 mm. So these are the, and all these particular symptoms, whatever are there, there should be waxing and as well as waning. Right? They should be waxing and as well as waning. This is what the diagnosis of multiple sclerosis according to your McDonald's criteria. And what we follow is the McDonald's criteria for the diagnosis of multiple sclerosis. Now, I said you about the 2 features. I have said you about optic neuritis and I have also said you about the diagnostic criteria of multiple sclerosis. Now, we will go back to this question now. Now, I have summarized the history in the beginning itself. Now, on the basis of this patient's presentation and MRI finding, which of the following statement is most accurate? The patient has MS and should be started on steroids and glatiramer. The patient has optic neuritis, she is a significant risk for MS. Patient has optic neuritis, no risk for progressing to MS. Patient has MS and she should be started on metoxantrone. What do you think of it? So what do you think at the end of the discussion? What is the answer? Yes. The answer to this particular question here is, yes, Broski. Let me tell you what is this waxing and waning. And I don't understand why most of you, I'll go back to the question again. Broski, I'll tell you your point. Waxing and waning, I'll tell you. Just give me some time. Most of you are answering A, right? Okay. You see, I'll just tell you the clinical summary of this particular patient. See how many symptoms she's having. She's having only one symptom. What is that particular one symptom? That particular one symptom is your pain in the right eye. Right? Okay. MRI, it is showing the presence of 2 white matter lesions. MRI criteria is fitting, but your clinical features criteria, is that matching your McDonald's criteria? According to McDonald's, MS means there should be more than 2 symptoms. Definitely that should be there. But according to the patient's history, she has only one symptom, that is retrobulbar pain on the movement. So she has only one feature suggestive of multiple sclerosis. But can it be multiple sclerosis? So the answer is no. Yes, Banu, you're correct. So the answer is she is not having multiple sclerosis, but she is at significant risk of developing multiple sclerosis in the future. Why? Because multiple sclerosis, it is more common in the middle-aged females. And what is the age of our patient? The age of our patient is 26-year-old woman. And the clinical feature, what she has only one clinical feature. And that is the reason why, according to your McDonald's criteria, this particular patient does not have multiple sclerosis. She has only optic neuritis. Okay, so whoever has answered B, that is the correct answer. Right now, some of you are asking me the waxing and as well as waning. Now, you take this waxing and as well as waning. Yes. See, yeah. So, waxing and waning. So, what do you understand by the word waxing? What do you understand by this word waxing? Waxing and as well as waning of the symptoms. Waxing means where there will be a flare of the symptoms. Waning means where there is decrease in the clinical features. Right? So that is what is the meaning of this particular word, waxing and as well as waning. So waxing, there is flaring of the clinical manifestation. Waning is that one where the clinical manifestations will reduce. That is what is called as waxing and as well as waning. Okay, so some of you have answered who were asking about waxing and waning. So I hope you have understood this word now. Okay, so now, so I'll just show you the MRI of a patient with the multiple sclerosis. Yes, so this is the MRI finding of these patients with the multiple sclerosis. So mainly in the periventricular area. Right, mainly in the periventricular area, they will be having these particular lesions. Right, and that is mainly the white matter lesions. And these particular lesions, there should be more than 2 in number, and there should be of size of more than 4 mm. Right, there should be size of more than 4 mm. No, waxing and waning is not the sign of MRI. Waxing and waning is the clinical manifestations. Yes, one last chance, you have answered it correctly. That is Dawson's fingers. What I am showing you in the MRI is your Dawson's fingers. Okay, very good. Now if you take the other investigations in this particular patients with the multiple sclerosis. So one is your MRI, which will diagnose your multiple sclerosis. The other things which will diagnose multiple sclerosis is your CSF. CSF, it will show the presence of oligoclonal IgG bands. Right, the presence of oligoclonal IgG bands. Next, in which case, that is in patients with the multiple sclerosis. Yes. Now, the other thing is visual evoked potentials. So if you take this visual evoked potentials, it will show decreased voltage. Right, visual evoked potentials will show the decreased voltage. And mainly to what is the purpose of doing this visual evoked potentials? Mainly to detect the plaque in the optic nerve. Right, mainly to detect the plaque in the optic nerve. Okay. No, albuminocytological dissociation, that one last chance you have answered, that is not here. That is seen, yes, Maya and as well as Pandey, you have answered correctly. That is in Guillain-Barré syndrome. That is seen in case of Freund syndrome, right? That is also seen in patients with the Refsum's disease. So Refsum's disease, Guillain-Barré syndrome and Freund syndrome, there you will have albuminocytological dissociation, right? Okay, now coming to the treatment of your multiple sclerosis, right? Treatment of multiple sclerosis. So if you see the treatment of multiple sclerosis, acute treatment, it is by methylprednisolone, right? Acute treatment, it is by methylprednisolone. Then, and if you take the disease modifying therapy, DMT stands for disease modifying therapy. Now, so can anyone answer me what is the drug of choice for multiple sclerosis? Drug of choice for multiple sclerosis. Very good, Panda, excellent. Right, so drug of choice for multiple sclerosis, that is your interferon beta. Right, that is your interferon beta. Okay, now let me just give you idea of the other drugs also. We have other drugs which include glatiramer acetate. Now where do we use this glatiramer acetate? This glatiramer acetate, the advantage is that it will reduce the attack rate in RRMS type of multiple sclerosis, that is relapsing remitting multiple sclerosis, right? Relapsing remitting multiple sclerosis, there we use this particular glatiramer acetate. Okay, next we have another drug called as natalizumab, and if you take your natalizumab, let me tell you that this is a monoclonal antibody, right? Most of the time you take this MAB, they stands for your monoclonal antibodies, right? Now what is the advantage of this natalizumab in MS? They will also reduce the attack rate, and not only that, the other advantage of natalizumab is this is the drug which will cause maximum reduction in EDSS. And what is EDSS? That is expanded disability severity score, right? Expanded disability severity score. Okay, so this is about your EDSS. Now, so can anyone tell me what is the contraindication for natalizumab? Contraindications for natalizumab. EDSS stands for expanded disability severity score. That means the severity of the symptoms can be reduced maximally by your natalizumab. Very good, Banu, excellent. So it is contraindicated in patients with progressive multifocal leukoencephalopathy, right? Contraindicated in patients with progressive multifocal leukoencephalopathy. So before giving natalizumab, you have to check for JC antibody. Only if JC antibody is negative, then only we give this particular natalizumab. Otherwise, we don't give natalizumab. All right. So that is about the story of natalizumab. And we have one more drug, right? We have one more drug that is called as fingolimod, right? Fingolimod. So fingolimod, what it will do? It will trap the lymphocytes, and they will prevent the entry into the CNS. See, basically your multiple sclerosis is what? That is your autoimmune disorder. So what does your fingolimod does? Fingolimod will trap the lymphocytes, which are the one which will produce the antibodies, and they will prevent their entry into the central nervous system, and thereby the antibodies are not being produced against your white matter of the CNS. Next, we have one more drug that is called mitoxantrone. So if you take this mitoxantrone, this is mainly useful in patients with SPMS, right? That is secondary progressive multiple sclerosis, right? Secondary progressive multiple sclerosis. So this is about your multiple sclerosis, right? So only the drugs I will just revise because investigations are easy. In acute phase, we give methylprednisolone. The disease modifying therapy, the drug of choice is interferon beta. You take other drugs like glatiramer acetate, they will reduce the attack rate in relapsing remitting multiple sclerosis. Natalizumab is a monoclonal antibody which will reduce the attack rate and they will cause maximum reduction in expanded disability severity scoring, and it is contraindicated in patients with PMLE. So that is the reason why progressive multifocal leukoencephalopathy. So that is the reason why we have to check for the JC antibody, and if it is negative then only we give. Fingolimod is the one which will cause lympholysis or will trap the lymphocytes. Mitoxantrone is mainly useful in those patients with a secondary progressive multiple sclerosis. So I hope you people might have understood this particular question now. So best prognosis in which type of multiple sclerosis? RRMS, it has best prognosis. It is the most common type and it has the best prognosis also. Right. So yes, dissemination in space and dissemination in time. See, dissemination in time. See, what should be according to your McDonald's criteria? What the McDonald's criteria says that is, now what should be the minimum gap? Okay, I'll just tell you one point based on this MRI finding and as well as locations, then you will understand it better. Yes. Now you take this, the MRI, right? Based on the MRI, that is dissemination of your location. See, in MRI, where all you can see the lesions, you can see the lesions in the periventricular area, corpus callosum, cerebellar peduncles, brainstem, juxtacortical lesions, and as well as dorsolateral spinal cord. In all these areas, you can see the lesions in the multiple sclerosis. So this is your dissemination in space where you are seeing the lesions in the MRI. And whereas you take dissemination in time is what, if the individual develops clinical feature, minimum that should be there for nearly around 24 hours, right? And that can progress even up to your 4 weeks, and the gap also should be minimum of 4 weeks between the development of the symptoms. So dissemination in space, that is the development of these plaques, hyperintense lesions, is at different places. Dissemination in time, minimum, if a symptom develops, it should be there for minimum of 24 hours. Then it disappears, there will be a gap of nearly around 4 weeks, and again there will be development of a symptom. That is dissemination in time. So yes, YOLO, I hope you have understood this. Okay, so at the end of the discussion of this particular question, my aim was to explain you about this particular thing. How to diagnose MS, how to treat MS, and how will you diagnose optic neuritis. Yes. Symptoms can be same or the symptoms can flare up. Anything it can be. It need not be same symptoms. Even some other symptoms can be added up in multiple sclerosis. Okay. So now we will move on to some of the, okay. I have discussed the clinical based question. Now let me discuss the true or false type of questions. Yes, there is a lesion in the medulla on one side, right? There is a lesion in the medulla on one side that may give rise to an ipsilateral hemiparesis. Tell me whether it is true or false. Contralateral hemiparesis, ipsilateral weakness of the palate, contralateral weakness of the tongue, contralateral third nerve palsy. Yes. So what about A? What about A? A is false. Very good. Okay, 1 second. I'll just use the other color. Yes. So what about contralateral hemiparesis? What about contralateral hemiparesis? Yes, contralateral hemiparesis will be there. I'll explain you why. What about C? What about C? Ipsilateral weakness on the palate. Ipsilateral weakness in the palate will not be there. That is a false statement. What about contralateral weakness of the tongue? Contralateral weakness of the tongue will be there. I'll explain you why. And what about your contralateral third nerve palsy? Will it be there or not? True or false? Right. So let me tell you that contralateral third nerve palsy will not be there. This is a false statement. Right. This is the false statement. Okay. So I will explain you everything now. Okay. So this is your false, true, false, true, false. Now let me take up the explanation. You take ipsilateral hemiparesis. See, for hemiparesis to occur, which particular structure should have been damaged? Your corticospinal tract should have been damaged. And where will be your corticospinal tract? Corticospinal tract, it will cross to the opposite side. So, if there is lesion in the medulla, the individual will have contralateral hemiparesis. Right? The individual will have contralateral hemiparesis. Okay? That is the reason why first statement is false statement. Second statement, contralateral hemiparesis will be there if there is any lesion in the medulla. That is a true statement. Now, coming to the story of your palate. Right? Coming to the story of your palate. See, now in the medulla, which particular cranial nerves will be there? So within the medulla oblongata, let me tell you what will be the cranial nerves which are present. In medulla oblongata, you have 9, 10, 11 and 12th cranial nerve. And you take your palate. This particular palate, it has two parts. It has your hard palate and as well as the soft palate. So you take this hard palate. Hard palate, it is supplied by the greater palatine nerve. Right, greater palatine nerve. Whereas the soft palate, it is supplied by lesser palatine nerve. Now, you take this, your greater palatine nerve and lesser palatine nerve. Both of them, they are the branches of which particular cranial nerve? They are the branches of your fifth nerve. They are actually the branches of your maxillary nerve. And maxillary nerve is the branch of your fifth cranial nerve. Right? It is the branch of your fifth cranial nerve. Okay. So, in the medulla oblongata, you don't have the fifth nerve. Right? In the medulla oblongata, you don't have the fifth cranial nerve. So, that is the reason why ipsilateral weakness of the palate is an incorrect statement. Right? Ipsilateral weakness of the palate will not be there. Okay. Next. Coming to the contralateral weakness of the tongue. If you take your tongue is supplied by 12th cranial nerve. 12th nerve is a motor nerve. But how will be the innervation? The innervation will be crossed. The upper motor neuron of the right side will go and innervate of the left side. And upper motor neuron of the left side will go and innervate on the right side. So there will be crossing of the nerves. So that is the reason why there will be contralateral weakness of the tongue is a correct answer. Next, contralateral third nerve palsy. See, third nerve, it is present in the midbrain. Right, third nerve, it is present in the midbrain. Now I'll just tell you some of your midbrain syndromes. Right, I'll tell you some of your midbrain syndromes. Yes, is everyone following or am I teaching to myself? Yes. So, if you take this particular story of your third nerve, yes, Banu, you're correct. That is, you should know about what is called the Weber syndrome. I'll tell you what is this particular Weber's. See, in Weber syndrome, which is the midbrain lesion, the individual will have ipsilateral third nerve palsy and contralateral hemiplegia. Right? Contralateral hemiplegia. Okay. So this is what is called as the Weber syndrome. Uh, yes. No, it should be contralateral. Right? It should be contralateral, not the ipsilateral. Right. Now, yes, Syed Ali, let me tell you about the Claude syndrome. So you take this Claude syndrome. In Claude syndrome, there will be ipsilateral third nerve palsy, and there will be contralateral hemiataxia also will be added to this, and contralateral hemisynergia, asynergia, right? So that is about your Claude syndrome. Okay, then yes, Broski, which symptoms you are asking me to explain again? Now, yes, Banu, let me tell you about your Perinaud syndrome. So if you take this Perinaud syndrome, in Perinaud syndrome, what will be the features? That includes bilateral vertical palsy, and there will be also bilateral paralysis of convergence. Bilateral paralysis of convergence. Why? That is due to the involvement of your superior colliculus. Right? That is due to the involvement of superior colliculus. Okay? So these are all your midbrain syndromes. Right? So that includes your Weber syndrome, Claude syndrome, and as well as the Perinaud syndrome. Now, to this particular Weber syndrome, right? To this particular Weber syndrome, for example, okay, right? So to this Weber syndrome, that is ipsilateral third nerve palsy and contralateral hemiplegia, what I will do is I will add contralateral intentional tremors. So what does this become now? What will be this syndrome? Yes, so this becomes what is called as Benedict syndrome. Right, this becomes what is called as the Benedict syndrome. Okay, right. So this is about your Weber syndrome. Right, next. Now I'll go back to the question now. So ipsilateral hemiparesis will not be there if the lesion is in the medulla, right? So there will be contralateral hemiparesis. Ipsilateral weakness of the palate will not be there, right? Because the palate is supplied by your fifth nerve. And contralateral hemiparesis of the tongue. Okay, right. So everyone is getting confused with the ipsilateral tongue or the contralateral tongue. Let me tell you. So you take this, whether the lesion is in the upper motor neuron or whether the lesion is in the lower motor neuron. For example, right? For example, don't get confused. I'll explain you this very clearly. So if the lesion is in the upper motor neuron, there will be contralateral hemiparesis, contralateral weakness of the tongue. And if the lesion is in the lower motor neuron, they will have ipsilateral weakness of the tongue. Right, ipsilateral weakness of the tongue. All right, so this you should not get confused. Now he is telling you that it is in the lesion is in the medulla. He is not clearly mentioning it whether it is in the nuclei. So when he is telling you that lesion is in the medulla, we should consider it as the upper motor neuron. But if he clearly mentions that lesion is in the 12th cranial nerve nuclei or the lesion is in the 12th cranial nerve, then the ipsilateral weakness of the tongue will hold good. Right? Many of you were getting confused. Kasoju and Maya and as well as yeah. So yes. So I hope this is clear for you now. Upper motor neuron, contralateral weakness of the tongue. Lower motor neuron, ipsilateral weakness of the tongue. Right. Yes, so medulla he has given, so you should consider it as a contralateral, so which becomes contralateral weakness of the tongue. So now going back to the question, yes, so this will be the answer. So ipsilateral hemiparesis, false statement. This is the entire story. Now I will add 2 points to here. 2 points. Now what are those 2 points is, we have what is called medial medullary syndrome and as well as the lateral medullary syndrome. Now you should know which are the vessels which are defective here. You take in case of lateral medullary syndrome. In lateral medullary syndrome, can anyone tell me what is the most common vessel affected? In lateral medullary syndrome, the most common vessel which is affected is vertebral artery, then followed by that posterior inferior cerebellar artery, that is pica. Whereas you take in case of the medial medullary syndrome, right? You take in case of medial medullary syndrome. So if you take medial medullary syndrome, the other name of medial medullary syndrome is Dejeron's anterior bulbar syndrome. So what is the vessel which is affected in medial medullary syndrome? Vessel which is affected in medial medullary syndrome. Right. So let me answer this. The vessel which is affected in the medial medullary syndrome to develop is, that is anterior spinal artery. Right? Anterior spinal artery. Very good. Yes, one last chance and Syed Ali, both of you are correct. So by the end of the discussion of this particular question, what did you understand here now? What did we discuss in this question? In this question, we have discussed the midbrain syndromes and I have also discussed the medullary syndromes. Right? Medial medullary syndrome and lateral medullary syndrome. I have just mentioned only the vessels, not the entire syndrome. Now, so if this question is clear, we will move on to the next question. Right. The next question is a clinical based question. Okay, we will take true or false and then I'll come back to this. Yes. You see this question. Again, another true or false question for you. No, it is anterior spinal artery in case of medial medullary syndrome. Yes, Dr. Broski. Now, the following may be seen with a lesion of third nerve or nucleus. Now, see, in this question he is very clear. What is that he is very clear? Third nerve or nucleus. That means what? It is a lower motor neuron there. Now, this is your true or false. Answer this question. First option, true or false? Dilated pupil. Yes. So when there is damage to your third nerve, so definitely these individuals, they will have a fixed and dilated pupil. It's a true statement. What about ptosis? Ptosis will be there or not there? Very good. So why do you think ptosis will be there? So why there is ptosis? Ptosis is due to involvement of which particular muscle? Very good. So that is your levator palpebrae superioris. Diplopia. Yes, diplopia will be there. Why? This is also a true statement. Why? That is due to the involvement of your extraocular muscles. Now, and in diabetes mellitus, what is the most common cranial nerve affected? Any one of you? In diabetes mellitus, what is the most common cranial nerve affected? Yes, one last chance. Diplopia will be there in all the cases. Yes. Right. Very good, Syed Ali. Yes, Sudhu, you are also correct. Yes, Kasuji, you are also correct. So the answer is the most common cranial nerve affected in the diabetes mellitus is the seventh, and followed by your third nerve. See, most of you are under the impression that in diabetes mellitus the most common cranial nerve affected is the third nerve. The answer is incorrect. The most common cranial nerve affected in your diabetes mellitus is the seventh nerve, and followed by that is your third nerve. Okay, and contralateral hemiplegia can be there, and this is what we have discussed about what is called Weber syndrome. Right, this is what I have discussed about what is called Weber syndrome. So this is also a true statement. Right, this is also a true statement. Okay, right. So this is about your true or false question, and I'll just show you one more true or false question, and then I move on to image based question. So in this question, what we have discussed completely about your third nerve palsy, right? Yes. Yeah. So another true or false statement: dysarthria may result from a lesion of cerebellum, Broca's area, hypoglossal nerve, basal ganglia, accessory nerve. No, Avinash Mukherjee, lesion in the third nerve will not cause hemiplegia. You should understand that if there is lesion in the third nerve, how will be the lesion in the third nerve or third nerve nucleus? See, lesion in the third nerve or third nerve nucleus is that where is the damage? The damage is in the midbrain. Right? The damage is in the midbrain. So in the midbrain, you also have corticospinal tract. And this corticospinal tract, if it is damaged, the individual will have contralateral hemiplegia. That you should understand. Right? That you should understand. So the individual will have what is called Weber syndrome. Yes, Avinash Mukherjee, did you understand this? Okay. Right. Now we will move to the next question. So dysarthria may result from a lesion of cerebellum, Broca's area, hypoglossal nerve, basal ganglia, accessory nerve. Okay. So dysarthria means what? Difficulty in articulation of the speech. Right? Difficulty in the articulation of the speech. Now, see, for the articulation to occur, these are all the structures which are required for the articulation of the speech. What are all required? Vocal cords are required, epiglottis is required, soft palate is required, lips are required, tongue is required, and oral cavity is required. All these structures, if there is proper coordination, right, if there is proper coordination, then articulation can be maintained. If the coordination between these structures, if it is lost, then articulation is gone. When articulation is lost, that is called as difficult articulation of the speech is called as dysarthria. Now, what are the structures which are required for your coordination? The structures which are required for your coordination is cerebellum and basal ganglia. So even basal ganglia, it plays an important role in the coordination. So these two structures are very important for the coordination. Okay, so involvement of cerebellum, true or false statement? So this is a true statement. Broca's area, if it is involved, dysarthria will not be there. This is a false statement. So if Broca's area is involved, the individual will have motor aphasia. And what about your 12th nerve? 12th nerve involvement will be there. True. Why? Because the 12th nerve is a motor supply to your tongue. Right? It is a motor supply to your tongue. So if 12th nerve involvement is there, the tongue will lose its nerve supply and there will be lower motor neuron paralysis and there will be difficulty in the articulation of the speech. So true. And basal ganglia, I have said you, it is required for coordination. And you take accessory nerve. Where does this accessory nerve supply? Yes, Syed Ali. Motor aphasia and dysarthria are not same. They are both are different entities. Accessory nerve, it supplies trapezius and sternocleidomastoid muscle. And these two muscles, they are not required for your speech. Right? These two muscles, they are not required for your speech. So that is the reason why it's a false statement. So at the end of the story, which are true, which are false now? Yes. So cerebellar involvement, dysarthria can occur. Broca's area, dysarthria will not occur. Hypoglossal nerve, dysarthria can occur. Basal ganglia, dysarthria can occur. And accessory nerve, dysarthria will not occur. Right? So this is about your dysarthria. Next, I will show you one image-based question and then we will wind up this session. So in this particular question, what did we learn? In this question, we have learned about what is called coordination of the speech. Right. So yes, let me take up the question of Syed Ali. You take the Broca's area. This is the one which will give the motor output for the speech. Motor output for speech. If this Broca's area is gone, the motor output for the speech is lost. So the individual cannot speak. The individual cannot speak. Okay. Whereas in dysarthria, what is happening? In dysarthria, the individual is speaking, but articulation is lost. Right? Articulation is lost. This is the difference between your Broca's aphasia and as well as your dysarthria. Okay. Yes, Syed Ali, did you understand that now? Broca's aphasia and articulation, dysarthria. Right. I will take up an image-based question and then we will wind up this particular session right away. Right. Now, so you see this question. Which clinical sign would you suggest in 53-year-old man with gait ataxia and these MRI findings? And you can see the MRI finding here. You can see this arrow mark. The options are gait instability, urinary incontinence, dementia. Second option, hypertension, tachycardia, diaphoresis. Third option, migraine, headache, limb weakness, breathing difficulties. Fourth option, scanning speech, oscillatory tremor of the head and nystagmus. So what do you think is the answer? Yes, very good. So most of you are answering it is correctly. Very good, great. So what is your diagnosis? So what do you think is the diagnosis? So what do you people think is the diagnosis? Everyone is answering D. Very good. I appreciate that. But who will tell me what is the diagnosis? So the diagnosis is spinocerebellar ataxia. Right? The diagnosis is spinocerebellar ataxia, or it is called Friedreich's ataxia. Right? And this spinocerebellar ataxia or Friedreich's ataxia, it is an autosomal dominant type of inheritance, and the gene which is being mutated is the frataxin gene which is being mutated, and the type of mutation what you will have is trinucleotide repeat. Right? Trinucleotide repeat. Okay. And these individuals, what will be the clinical manifestations? They will have ataxia of the trunk and limbs. They will also have nystagmus, right? And they will also have tremors, oscillatory tremors, where in the head and trunk, right? Yes. So this will be the clinic, and they can also have even mild dementia, right? Mild dementia. Okay. So now, how will you diagnose? So this is about the features of your spinocerebellar ataxia or Friedreich's ataxia. I'll just go back to the question again. Don't worry. Now, the MRI will show. Now, what is this MRI finding actually? This MRI finding, it is suggestive of your cerebellar atrophy. Right? It is suggestive of your cerebellar atrophy. Okay. Yes. Now, so you see here, the speech, scanning speech is a sign of your cerebellar lesion. Oscillatory tremors, right? That is a feature of your cerebellar lesion, and as well as nystagmus. See, what is oscillatory tremors? That is what the Priyanka Sharma is asking. Oscillatory tremor of the head is like nodding of the head. Like, yes, this is what is called as oscillatory tremors. So can anyone tell me one cardiac condition where do you have this particular nodding of the head? Which cardiac condition you will have this nodding of the head? Nice. Scanning speech and slurred speech is different. Very good, Banu, Sudu, good. That is your AR, aortic regurgitation. What is that sign? What is the sign? Not hypertrophic cardiomyopathy, it is in aortic regurgitation. Yes, Banu, can you tell me what is this sign? Nodding of the head in aortic regurgitation. That is called Demusset sign. That is called Demusset sign. All right. So now we will take up the other options. See, the presence of the migraine headache, limb weakness, and breathing difficulties. Where do you come across this? You will come across this in patients with alcohol withdrawal or in case of serotonin syndrome, right? Or in case of serotonin syndrome. Okay. Then you take the first one. Gait ataxia, urinary incontinence, the presence of dementia. What is this particular feature suggestive of? This triad. This is a triad where in case of normal pressure hydrocephalus, right? Normal pressure hydrocephalus. So in normal pressure hydrocephalus, you will have a triad. What is that? Gait ataxia, urinary incontinence, and dementia. And you take the second option, hypertension, tachycardia, and diaphoresis. Where do you have this? You will have this in patients with Arnold, sorry, Arnold-Chiari malformation, right? Arnold-Chiari malformation. Okay, so this is about your image-based question. So the individual, I'm sorry, the presence of gait ataxia suggests you of cerebellar lesion. And where do you have the features of cerebellar involvement? Scanning speech, oscillatory tremors, and nystagmus is the features of your cerebellar involvement. And where do you have first option? Gait ataxia, urinary incontinence, dementia. It is a triad where you see in patients with normal pressure hydrocephalus. Hypertension, tachycardia, diaphoresis, they are the features of your Arnold-Chiari malformation, or even your sympathetic overactivity also. And migraine headache, limb weakness, breathing difficulties, that is a feature of your alcohol withdrawal or serotonin syndrome, right? So this completes the discussion of this particular session. So at the end of this session, what did we learn? We have learned about this optic neuritis. We have learned about the multiple sclerosis. We have learned about third nerve palsy, we have learned about medullary and midbrain syndromes, and we have learned about the coordination, right? So, yes, Syed Ali, you can correlate that. Option B is a classical sign of pheochromocytoma. Excellent. We can take that. Right. So this is what we have learned in this particular session. Right. So and again at 9 o'clock now, I have another session on Unacademy platform. And if you want to know my sessions, please press the follow button on my name on this Unacademy platform. Then you will get the notifications whenever my classes are there on this Unacademy platform. All right. So I hope you people might have enjoyed this particular session. Yes or no? So, my dear students, can you please give me the feedback of this particular session? Banu, you want Devick's disease? Okay, I'll just show you the Devick's disease. This is your Devick's disease. In Devick's disease, you will have cervical cord involvement. Yes, YOLO. Devick's disease, this is also called neuromyelitis optica. Right, Devick's disease, this is also called neuromyelitis optica. And mainly, there will be involvement of your cervical spinal cord. Right? And this particular Devick's disease, in these individuals, there will be involvement of even the optic nerve and spinal cord. And these individuals, they will have malignant course. Okay, right. Yes, Maya, you want a session on epilepsy? Okay, so fine, I'll take up a session on epilepsy in the upcoming days. So with this, I'll just wind up the session. Yeah, the next live topic I have at 9 o'clock today, and that particular topic is on very important topic in the pulmonology, that is ARDS, acute respiratory distress syndrome. And I will be taking that topic on Unacademy platform, and it is a free session. You all people can follow on that, and I am going to tell you the concepts on ARDS. I am going to teach you the mnemonics in the ARDS, and I will be also giving you the updates on the new criteria in ARDS. Okay, so thank you very much and see you at 9 o'clock.